name is Dr. John Lipman, board certified interventional radiologist. Basically specializes, one of his specialties is going to be in the treatment of uterine fibroids. He has performed over 9,000 uterine fibroid, what they call embolization procedures, basically making him one of the world's experts in this area. You know, fibroid problems are very common. People come in, you know, wow, I'm just going to say numerous times complaining of issues associated with fibroids, anything from just pain, irregular bleeding, cramping, you know, you name it. I mean, it's just one of those things that's just difficult to treat, difficult to manage. And, you know, women really just, wow, they just have a hard time dealing with it. And, you know, it's a problem that spans pretty much half of their life, you know, from the time they start menses all the way to menopause, and then some after. Well, tonight I got this doctor here. He's going to talk to you about something that could give you relief. Okay. And I'm going to just ask Dr. Lipman to say hello and just start off by just telling us a story, tell us all about himself, and we'll go right into this whole fibroid issue.
Well, thanks very much for having me. It's a pleasure. And as you stated, fibroids are an extremely common condition in women. It's the most common pelvic tumor seen in women. 1 of every 3 women, adult women, have these benign tumors, and it's estimated that 80% of African American women have these benign tumors. So it's extremely common in all women, but it's particularly common in women of color. And I see fibroids every single day at the Atlanta Fibroid Center. I'm the founder and medical director. I've been practicing here in Atlanta for the past 31 years. And so I see fibroid patients every single day. And as you said, fibroids make women's lives, a lot of women's lives, miserable. It's the most common reason why women have heavy periods. So here we are tonight, 2 guys talking about women's periods. Go figure. But it's my life's work. And as I say, we have an incredible procedure called uterine fibroid embolization, UFE. It's truly one of the biggest medical breakthroughs for women. And yet our issue is that most women never hear about it. And that's really a shame. We've been doing this UFE procedure for the past 25 years. It's available throughout the country, but it's what, as you mentioned, I specialize in. I have one of the largest worldwide experiences in it. And it is truly transformational for women. Our patients come into the center suffering with fibroids, and we'll get into how they suffer. We mentioned heavy bleeding and pain. Those are the most common issues. And so they suffer quite a bit, and they come into the center. The procedure that I do, this UFE procedure, takes about 30 minutes or so. They have a several-hour recovery in our center, and they go home with a Band-Aid. That's it. And their uterus, because most of these women have been told the only thing that will help them is a hysterectomy. And if you learn one thing from what we say tonight, the one nugget here is no matter what your gynecologist tells you, you do not need to have a hysterectomy for benign fibroids. It is an option, but in my opinion, it should be the option of absolute last resort, because UFE is so good. The success is a little over 90%. Wow. So 90% of patients can get the relief from their horrible symptoms. They avoid the risks and long recovery of a major operation. And importantly, and often underappreciated by many physicians, they get to keep all their parts. Their uterus, I hear every day that, Doc, my gynecologist told me, since I'm not interested in having any more children, I don't need my uterus anymore. That's just absurd. It's absolutely absurd. So there's a lot to unbundle here, but that's what I do. I do it every day. UFE is tremendous, and we can talk for as long as you like about what it is and how we do this. And it's just a great procedure. Everyone needs to know about it, because if you're a woman of color, likely either you're suffering or know about fibroids, or you know somebody that is. And we got to stop these unnecessary hysterectomies. Hysterectomy is the second most common surgery performed in the United States. Let that sink in for a moment, because both of us don't have a uterus. Half the population doesn't have a uterus, and yet it's the second most common surgery we do. And the most common reason why we do this crazy surgery is not cancer. That would be appropriate. With the most common reason by far are these benign tumors. So why? And it's African-American women that are getting this. So in a sense, why are we amputating African-American women? They're young. The average age is less than 40. Young African-American women for benign disease. It's insane. We got to stop this.
Oh my goodness, that is horrible. You know, you mentioned that. I was just thinking how many of these surgeries I've actually sat through or stood through, so to speak. You know, I don't know what I can't remember the indications for hysterectomy. You know, I've seen uteruses come out the size of, you know, grapefruits, and some as the size of watermelons. The sizes of these uterus. You know, and you're telling me now, after hundreds of surgeries I've probably stood through with you know, these hysterectomies, that 90% of them would have been easily handled by just a simple embolization procedure.
Right. Go home the same day with a Band-Aid. 5-day recovery.
Band-Aid. That's unbelievable. Instead of the scar that they have right at the lower part of their belly. You know,
right. Or if their uterus is above their belly button, which we see a number of those ladies, they get the vertical incision. That's even worse. It starts at the breastbone and goes vertically all the way down to the pubic hairline.
You're going to make a lot of young ladies unhappy telling them about this procedure that they could have avoided it. Now, you know, give us an idea of the type of patients, you know, what do they come in complaining of? We'll just go back to the basics.
So what
are the most common complaints?
The most common complaints are heavy bleeding, heavy periods, pelvic pain, and increased urinary frequency. The fibroid tumors, and women can feel them if they're big enough and they're in the front of their uterus. They can feel them. They're hard and firm. They're like rocks. And so depending on where they're located in the uterus will determine what the symptoms are. So there are three main locations of fibroids in the uterus. There are ones that are located just underneath the lining. That's called submucosal fibroids. Those cause the heavy periods. There are ones that are underneath the outer covering of the uterus. Those are the subserosal fibroids. Those press on things, whatever's next to. So if the fibroid is growing outwardly and pressing on the bladder, those ones that are, because what sits right in front of the uterus is the bladder. So these anterior subserosal fibroids will be right on top of the bladder and act like a paperweight. And so the bladder doesn't get to fill appropriately. It basically starts to fill with a little bit, and then the rock won't let any more urine into the bladder. And so they feel like they got to pee. And so they run to the bathroom and they empty just this small amount. And it's like, it felt like I really had to go. Well, if you understand what's happening, the fibroid's not letting the bladder fill. And so they've got to keep going more commonly and wake up in the middle of the night. Fibroids that are located in the muscle of the uterus, that's the most common type, the intramural. It depends on which way they grow. If they grow outwardly, like subserosal, they'll cause more bulk-related symptoms, pressing on pelvic nerves to cause pain, pressing on the colon to cause constipation, pressing on the bladder, as we talked about, for urinary frequency. Or if they grow inwardly toward the cavity of the uterus, toward the submucosal ones, they'll have heavy bleeding. So the intramural can cause bulk-related symptoms, bleeding, or both. So depending on where your fibroids are located, kind of determines which one of, or all three. I mean, typically my patients have all three of the big three symptoms: heavy bleeding, pelvic pain, urinary frequency. And so they're miserable. These periods are not only heavy, they're like crime scene heavy. They're horrifically heavy. And sometimes, believe it or not, the heaviness is going like, they just feel that that's part of aging and part of their normal, because they've been bleeding so heavily so long. They think it's normal. And then they might ask their mom, who also suffered with fibroids and had heavy periods, And she says, well, that's, we're heavy bleeders. And so they don't recognize that that's not normal. So we can talk about what's a normal period. It should be several days long, and it should be small amounts of blood loss, teaspoons of blood loss, not copious, like blood exploding and running down the patient's legs and having to change more frequently than every 3 or 4 hours. These women will change less than an hour, 2 pads at a time, and wear period panties or diapers even, and have these big clots. You can have little tiny clots, but I'm talking clots the size of your fist and your palm, big gushes of blood. I mean, it's just horrific. And so when you lose that much blood each month, you get anemia, which is a deficit of iron and hemoglobin, which are carried in the blood. And so now these patients are fatigued, they're tired, they're weak, they get migraine-like headaches. They might chew or crave ice. And I asked them, like, do you chew or crave ice? And they're like, wow, he's clairvoyant. How did you know? like, is that like, can you see that? And like, no, you're having these horrific periods. Like that's a sign of chronic anemia. And sometimes down here in Georgia, they might chew the Georgia white clay, the kaolin, the main ingredient in kaopectate is actually like clay, and it's crunchy, and they'll chew clay or dirt or cornstarch or inedible things, and it's embarrassing. I mean, they don't know why they're doing it, and they can't stop it.
That actually makes them more anemic.
It makes them more anemic. And so, they go to their gynecologist with these symptoms, and they might get started on the first line of therapy is the medical therapy, which unfortunately for fibroids isn't very good. It consists of non-steroidal anti-inflammatories like ibuprofen or tranexamic acid, or some form of hormonal therapy, birth control pills, progestin-containing IUDs. But the problem is, while we don't know where fibroids come from, they grow with estrogen. And what's in hormonal therapies and birth control pills? Estrogen.
Right.
So it might lighten the flow for a little while, and the gynecologist will try to lighten their flow with birth control to build up their iron and hemoglobin enough so they can operate on them. But in the background, it's like pouring gas on these fibroids. It makes them grow much bigger than they already otherwise would. And so they jump right from this medical therapy that's not going to work very well right to the surgery. And they ask them, are you interested in fertility? And if they say yes, they get a myomectomy or offered a myomectomy, cutting out some of the fibroids. And we can talk about the failures of myomectomy, because you can't get them all out. Or if they're not interested in fertility, you get the B line right to hysterectomy. And they don't mention UFE at all, even though it's been available in this country for the past 25 years.
Wow. Let's go back just a little bit. And I know a lot of people that suffer from fibroids, and one of the questions that they always have for me is, where do they come from? And you just said no one really knows, and it's just, I always try to tell them it's like a mole on the skin that just appears. It's the same thing in the uterus, but in there they could grow, unbelievably large. I know they're hormonal dependent, but
yes,
we don't really know where they come from. And you mentioned that they're benign tumors. Now, I know that there are some instances where they can have a small focus, and that's very rare, of something rare. And that can be concerning sometimes, but for the most part, they are benign.
Correct. Yeah, they're benign. And African-American women get fibroid tumors earlier in life. They tend to be bigger and more numerous, and they're more likely to end up having a hysterectomy. And that's what we want to stop. We want to educate patients so they know all their options. Women are entitled to know all the options available to them, but they're not getting all the options. They're only getting the surgical options, and that is only part of the story. And the gynecologists really have let a lot of women down by not telling them about UFE and telling them about all the options. And so that's why I'm so grateful to be on this show and others to try to educate people to ask about UFE. And You have to get a second opinion from a different type of doctor. I'm a medical doctor. I'm an interventional radiologist.
Yes.
It's a different type of medical doctor than the gynecologist, who's a surgeon and a different type of physician. So you need to get a second opinion. And that's why it's so important to know about UFE, because unfortunately, even though you should get told about it by your gynecologist, most won't mention it.
You know, I tell you, interventional radiology and, of course, one of my other favorites, transplant, are pretty much two of the most underutilized services available. I mean, you know, one major issue that I've always noticed is that the only time you really see them is in institutions. And when we saw them, they were always called on for critical procedures, so to speak, you know, interventional radiologists. But if you don't ask them what the scope, you know, the things that they can do, you know, then you would never know, you know.
Right.
But before we go more into that, the myomectomies, you mentioned those, you know, women that want to still have children are offered myomectomies, and you say they may remove one or more of them to try to help them. Can you elaborate on that a little bit?
Sure. And that's the surgical option for women that are suffering with fibroids that are interested in fertility. So the myomectomy is a surgical procedure. It can be done open or laparoscopic. Usually with fibroid patients, at least the ones I see, the vast majority of them don't qualify for laparoscopic or robotic surgery because of the size of the uterus. There's no room to put their metal straws in, the laparoscopic straws. So they're going to do those open. So most women suffering with fibroids are facing open surgery, and it's an open incision. If the uterus is below the belly button, they will do a horizontal incision, hip to hip, like a C-section. And if it's above the belly button, they're going to get a vertical incision from the breastbone vertically all the way down to the hairline. That's a big time surgery. And sometimes they start horizontally and realize they can't get the skin up enough exposure, and then they slit them vertically, and it's like an upside down T.
Yes.
And again, remember, these women are young. They're you know, late 20s, 30s, maybe 40s. And the biggest Achilles heel, besides the fact that these procedures are done surgically, with all the risks that entails, because every woman going in for myomectomy has to sign a piece of paper saying, you understand if we get into too much bleeding, and these things bleed like crazy, or we can't reconstruct your uterus after taking these fibroids out, you're going to wake up with a hysterectomy. And that does happen. And so they have to understand that, and they sign this piece of paper. But besides those points, the biggest Achilles heel of myomectomy is very rarely do they get the majority of fibroids out or all of the fibroids out. Usually there's way more fibroids than they could possibly take out and still reconstruct and have a functioning uterus left. So they take the biggest ones they can get out safely and then sew the uterus up and sew the woman back. So now she wakes up from this major surgery with at least as many fibroids number-wise as they took out, maybe more. So they got all these living fibroids. When she wakes up, all they have to do is start growing. You know, they took out some of the bigger ones, but the smaller ones they left behind grow up, and now they become the big ones. So the recurrence rate for myomectomy is 11% per year. Wow. So over half the women within 5 years are going to need another something. And so they'll ask the woman, are you still interested in fertility? Because if you are, have another myomectomy. And if you're not, now get a hysterectomy. So I've seen women have had 5 myomectomies, and now they're coming to see me. Now imagine every time you cut on that uterus, the fertility drops like a stone. So after 2 myomectomies, and I don't think you should ever do more than 1 ever, no matter what, but after 2, there's really no fertility left to speak of. And so you need something global. Obviously, you know, there's way more fibroids than you can take out surgically. How about doing something that is a global therapy for fibroids? Oh, I know, UFE. UFE knocks out every fibroid. It doesn't matter how many you have, how big, where they're located. It's a global therapy. So the recurrence rate after UFE is very low. I've seen some patients grow some new fibroids. I've treated some patients, say, in their 30s. Now they're in their late 40s or early 50s, and they grew some new fibroids. Okay, get a second UFE, but that's unusual. Most patients, particularly if they're in their 40s, when they get their UFE, it's a one and done.
Wow. Now, let me ask a question now. So now we're at the point now where you're talking about the embolization procedures, that it's basically one and done, and it's a global procedure. Tell us what embolization is.
Well, what we want to achieve is we want to knock out the blood supply that are keeping these fibroids alive. So imagine there's a left uterine artery and a right uterine artery, and they're each like a big tree. So I can negotiate a little tiny catheter like a piece of spaghetti, and I can, under X-ray, guide them into each uterine artery one at a time. So I'm in, say, the right uterine artery, and it is a tree. And so I'm in the big trunk of it, and it starts to branch and get smaller and smaller branches out to the leaves. The fibroids are the leaves of the tree, and I know what size those small peripheral branches are, and I can send these particles of PVA, polyvinyl alcohol, that are sized for these tiny peripheral branches, and it plugs them up. The big trunk and the main branches stay open, so the uterus stays alive. The uterus is totally alive, and we've had numerous children after UFE. I've had multiple twin births after UFE. So the uterus is alive, but hopefully every single fibroid is dead. And as they die, they will start to soften and shrink. And as that softening and shrinking go on, a woman's symptoms start to fade away.
Now, so basically, if I view this as a tree, the tips of my fingers would be where the fibroids are, and you can actually inject something right through into the tips of my fingers and to basically cut off the blood supply to each of these fibroids.
Yep, I'm a tree surgeon. I'm pruning the tree.
You're pruning the tree.
From the inside. It's all done from the inside. I do one uterine artery, then I go around and do the other. I can get both uterine arteries from a one-sided approach. And then when I'm done, I pull the catheter out, and there's a Band-Aid that goes at the top of the right leg where I entered. It's the right common femoral artery.
Now, are there any complications from embolization procedures?
Sure. Any procedure has risk, but imagine a risk of a procedure where you're going home the same day with a Band-Aid versus the risks of being cut open surgically. Now, there are some women that do not menstruate permanently after UFE. Now, in the close to 10,000 of these that I've done in the past 25 years, I've never seen that happen to anybody under the age of 40. As you get above 40, you start to see it. So 40 to 45, about 1 to 2%, 46 to 50, about 5 to 10%. You get above 50, now you're looking at like 20% or so. But most of the women,
their menstrual cycle just stops, or what happens?
Stops. Mm-hmm. And when I mention that as a risk, most of the patients that I tell that to they burst into immediate laughter, sometimes uncontrollably for several minutes, because imagine, they think that's tremendous. They're not interested in fertility, and they're having these horrific periods. Now that's because everything they do revolves around their menstrual. It's really burdensome, and to be liberated from that would be a blessing.
It's a side effect, but it's like, wow, wouldn't they be happy about it? That's like, well, please, can you make that happen? I can almost hear them saying that.
Exactly. They will say that. And so, I say, depending on the age, it's a low chance. Now, again, nobody yet under 40, because that's where typically, there are women that are interested in fertility that will see us, and I can tell them confidently that it's never, in the 25 years I've been doing this, I've never seen anybody your age where that ever happened. So you'll menstruate, it'll just be a lighter flow, no more gushy, floody, clotty stuff. It's a light, normal menstrual. And sometimes they don't recognize what normal is. They've been doing this horrifically heavy one for so long. It's transformational, because having to know where every bathroom is, and having extra people will come to my office bringing an extra change of clothes. everything they do, whether they work or not, whether they have relations or not, whether they can go on trips or not, whatever they do, everything is determined by their menstrual. And it's this, not only is this the physical demand on them from this anemia that we talked about earlier, being tired and weak, but it's a mental thing because they just dread, oh my gosh, I'm going to go through another cycle again. I can't believe I'm going to face this again. And they got to push through it. I mean, it's very physically and mentally draining for these women.
Wow. So this actually gives women back control over their lives. You know, for those
Absolutely.
people that suffer from this problem.
It's,
you know,
truly transformational.
Is there anyone that would not be a candidate for this procedure?
There are rare instances. There are unusual circumstances. There are some women that we get MRIs on everybody. Usually they've had an ultrasound, but ultrasound is a very low resolution imaging tool. MRI is fantastic. It's like high definition television. And sometimes you see things on MRI that the fibroid does, you know, because it doesn't really have the typical appearance of a fibroid. You might be concerned that you might be dealing with a cancer. Even in those circumstances, oftentimes it turns out to be just kind of an ugly fibroid. But we will tell those patients, you know, for safety's sake, I think you're going to need surgery. But or if there's a fibroid that's actually sitting in the cavity of the uterus, it's an unusual location. If they're small, we don't worry about it. But if they get to a certain size and we embolize those patients and just do that, that fibroid's going to come out like a baby. It's in the cavity already. And if we embolize them, they'll try to abort that. So this is a very good way to communicate with the gynecologist, and we'll do what's called a combined approach, where we will set up in advance. The gynecologist will come in 3 weeks after we do the embolization and take out that one fibroid from the inside before the patient could abort it. It's called a combined UFE and hysteroscopic removal. They come in from the inside vaginally and take that one fibroid out before she aborts it. So we knock out all the fibroids, including the one in the cavity with the UFE, and they come in and they love doing that because when they normally do a hysteroscopic myomectomy, the fibroid is alive and they only have a short amount of time to get after this fibroid, and it's very vascular and it bleeds a lot. But after a UFE, the fibroid is dead and they get giddy on it. They send me videos. They love doing this. It's so easy. It's a layup.
Oh, wow. Unbelievable. Now, with that, you know, so we have hormonal therapy or medical therapy. We have hysterectomy. This is what we're all accustomed to, you know, and now we have what you're talking about is uterine fibroid embolization. Now, why isn't this the standard of care for people that suffer from these heavy periods?
It should be. I mean, the gynecologists have done women a disservice. Not every gynecologist, but clearly we've done numerous studies on this over many years. Most gynecologists won't mention UFE to their patients. They're surgeons, and surgeons want to operate. And
I mean, it's the number 2 surgery in the, number 2 surgery. They do a lot.
Exactly. For benign disease. And we don't need to be doing this. We have a horrible legacy in medicine about hysterectomy and our treatment of women of color, particularly here in the South. I mean, you talk about the Mississippi appendectomies and Fannie Lou Hamer, and all the unnecessary surgeries. I spoke at Tuskegee University not long ago, and 3 women came up to me after my talk. They were crying. They were all under the age of 30, and they had a hysterectomy, and they were suffering so badly. They tried to hold out, but it's miserable. And so they kept getting told that was the only option, and they succumbed to it. And now they will never have childbirth. They will never, and they were pretty upset about the fact that nobody told them, because we've been doing this 25 years. This isn't anything new or experimental. It's well proven, safe, and effective. And yet here are these very young women. I have daughters that age. I mean, it was very tragic And so, that's why we want to try to educate people about this. And my talk was essentially, this is the Tuskegee experiment of our time. I mean, I know the Tuskegee experiment, is something that really starts raising people's blood pressure, and it's very, anxiety provoking. But, that was an experiment done on African-American men, poor sharecroppers in Alabama, started in the 1930s, that had syphilis, and they volunteered to get free health care and a free lunch. Over the course of this trial, where we didn't have really any great therapies for syphilis initially, penicillin was discovered, and during the Second World War, we had the ability to treat these gentlemen, and they didn't tell them about it. And so they just suffered miserably with syphilis. And so, here we have again, in 1972, when they said, this is over with, this will never happen, we have informed consent, this will never happen again, and so forth and so on, the usual kind of stuff. Now we have a procedure that women aren't being told about. It's not poor, they're not necessarily poor, they're Black women now of all different socioeconomic strata not being informed about a procedure that could literally transform them and take care of this problem that they suffer with. So the parallels are not that dissimilar, and it's really disturbing that we're all these years removed from Tuskegee, and yet almost like, here we go again.
I'm wondering, there are a lot of issues that come into, when you start thinking about this, not to mention, the more serious issue with you. I can understand from a GYN perspective, without hysterectomies, they have really not much else to do, especially if that is their bread and butter. And that really is their bread and butter, given the number of surgeries that they do. And, it's easy. I can see it's easy for them to treat medically, take to the OR. So they may operate 4 or 5 times a week, doing the same type of procedure, which is pretty much, giving, give or take a couple, so to speak. Like I said, I've sat through hundreds of them. Lots of hysterectomies. And, outside of that, there are a couple of other problems, ovarian issues that they could deal with, and cervical issues, of course. But the uterus is like their number one. That's their number one thing there. Yep. So I can understand why it's not pushed in essence. But the reality of it is that, that's one of the issues that we have with medicine, is that sometimes the things that work best, that would benefit more people, the information is not getting to people. It's not getting to people. I've been aware of uterine embolizations. The issue is, who doesn't? So when you have your medical doctors, you take a panel of them, and where do you write the consult? The consults are going not to interventional, but they're going where? To the GYN doctor.
Right.
And so what happens? We don't know where the consult is, So the thing is that, and that's one of the issues that we have is intervention. They're in the hospital, and the thing is that I've always, whenever we called intervention, it was trauma related, trauma. So we always thought that intervention was part of what? Trauma surgery. Okay. Right. So nobody ever calls on him. I used to call the interventionalist, when he was around, say, hey, I'm having difficulty with putting a line. I need you to put a CVP or, in the patient for me. Go put a line because the patient's overweight, etc. So can you get a line? So he was always happy to do that. So I know they do other things. And they started talking about all the other procedures they do. I said, really, you guys do all that? How come we don't know about this?
Well, we don't. Yeah, we don't know because, as you say, our roots are in the hospital as being the physician's consultant. Certain doctors will have an issue or a problem dealing with a certain patient that they need help with, and they'll call us in. Like you said, we are expert at stopping things from bleeding. In fact, this is how the UFE procedure was discovered. We we've been embolizing uterine vessels for postpartum hemorrhage for a long time. You know, and again, it's another thing that's underutilized. We could be, you know, there's a lot of Black maternal mortality over postpartum hemorrhage that we could be helping with more than what we're doing. But that's where we had the history of, you know, least familiarity with stopping, you know, bleeding vessels postpartum. But we morphed into trying to make the surgeons' lives easier by stopping things from bleeding preoperatively. So somebody has a cancer of the kidney, let's say, which is a very vascular tumor. The surgeon might say, can you embolize this tumor for me? And so we'll knock out the blood supply to this malignant cancerous tumor before they go to surgery. And so we would do a lot of that. So the patient gets embolized and then they go right to the operating room, and it's an easier, safer surgery for the patient, for the doctor, less anesthetic time and so forth. Well, somebody got the bright idea in France back in the 1990s. Why don't we do that prior to hysterectomy to make it an easier hysterectomy? We'll have the interventional radiologist embolize the fibroids pre-hysterectomy, and that'll make it an easier surgery. No one had ever thought about doing it for benign tumors before. So this group in France in the early 1990s started doing that. And in France, the healthcare system is you know, it's rationed care, it's socialized medicine. They want to, you know, the European and Canadian model they want to bring here to this country. And so it's rationed care. So what happens is, unlike in this country, they were embolizing patients and then they were discharged home to wait for their elective surgery. You can't just, like in the United States, you go right to the OR. Well, you can't do that. It's, you know, anything, only emergencies get done. This was an elective surgery. So they got their embolization for fibroids. They were discharged home, and then they had to wait 6 weeks, 7 weeks, 8 weeks for their elective hysterectomy. Well, what happened? Their symptoms went away. During that 6, 7, 8 weeks they're waiting at home, all of a sudden, all the symptoms went away. So they called their gynecologist. They're like, do I still need this hysterectomy? Because I feel great. And the answer was no. All you had to do was the first part. You didn't need the second part. And so the gynecologist that was working with the IR in France, his best friend, I guess, was the chief of OBGYN at UCLA. And he called him and said, you better look at this. This is pretty interesting. So he got Scott Goodwin, who's the interventional radiologist at the time, chief of IR at UCLA back in the mid-90s. He did the first 11 patients in the United States and published it in the mid-90s. And I happened to be at the same conference. He was, you know, publishing, you know, he was talking about his data. I happened to be talking about embolization of liver tumors. And I'm listening to him talk. I'm like, man, I'm in Atlanta. I could help a lot of people. And so I went back to Atlanta and did the first one in Georgia many years ago. And I've been doing them for over 25 years now. And it's a tremendous procedure that transforms so many women's lives. And we could be helping so many more women, because there's over 1 million women in the United States that are sitting on the sidelines suffering with fibroids. They don't want hysterectomy, and I don't blame them, but they don't know of any other option.
Wow. You know, and it's like, I'm sitting here. Yes, I know there's probably more than 1 million women out there suffering from this problem. And I'm like, you know, I mean, people just need to hear it. They just need to hear the information, you know, and then the docs need to, you know, refer to intervention.
Right. I mean, but easier said than done, my friend. I'll give you I mean, a number of years ago when Oprah was doing her show and she was like, you know, just killing it, I thought, if I can just share the information with her, like I can then it would get out there, and then it would be over with. Everyone would know about it, and then that would be great. And I talked to one of her producers, and the producer was like, oh my gosh, this is incredible. And I sent her videos and testimonials from patients, and they're like, this is I can't believe this is incredible. Where has this been? I'm like, well, we've been doing it, back then we had been doing it for like 10 years back then. And they're like, oh my gosh, you're like,
She never got
you better.
She never brought you
No,
That's horrible.
never got on. No, because what happened? Think about it. This person's not a medical person. She was excited. She saw all the stuff. Talked to my patients, and she brings the information and gets it vetted with her, women's health expert. Guess what type of physician that is?
GYN?
And it just gets squashed. That happened on CNN here in Atlanta. That happened at Oprah. That happened with Dr. Oz. They've done a very good job of keeping this on the down low. That is
like, I know that's what happens. That's what I said. We send the consults to GYN. Same process that you went through. It gets stopped,
Yeah.
And I remember, for me, I had his direct number, the interventional direct number. So anytime I needed anything, I didn't have to write a consult and leave it on the table. I just call up and say, hey, I need you for something, And now, you're looking at this and you're like, wow, do you realize, you're in Atlanta. I can only imagine, how many people you are seeing. When I was a resident, and I used to work I remember I spent a lot of time in the emergency rooms during my training. And every time I seemed like I went in there, I wasn't really interested in trauma. Everybody was, the show ER had just come out, and everybody was interested in being trauma, and ER. Me, I always ended up in Kings County Hospital on what they call C5, which was the women's GYN floor. And I tell you, in the course of a night at Kings County Hospital, I would see 100 women with the same problem all night long, and sometimes, because you're on call every third night, so sometimes you see the same woman night 3, night 6, night 9, and you're treating them over and over again. And the only thing you can say, well, we're trying these medications, they're not working, let's refer you for surgery, refer you for surgery, So when it came down to the surgical rotations, now I'm standing in there watching all the women come in for hysterectomies. And wow, how long does this procedure take? You said 30 minutes?
30 minutes. And then there's a several-hour recovery, and they go home with a Band-Aid. And then there's about a 5-day recovery at home. And then we see them back in the office 3 months after the procedure, and it's usually a lot of hugs. They just can't believe they've got their life back. They're so appreciative. It's transformational.
Man, 2 hours. 2 hours. 4 surgeries is 12 hours. And I've been there. 4 embolizations is 2 hours. Oh my goodness.
And what happens? The other kind of problem here is what happens to a woman when she loses her uterus. As I say, all the time I hear, well, my doctor said, since I'm not interested in children, or I'm not interested in any more children, I don't need my uterus. And, losing one's uterus causes a lot of issues, whether it's psychological, like a man being castrated, sexual dysfunction, and it's embarrassing to talk about, but there's a lot of sexual dysfunction after hysterectomy, loss of libido, loss of orgasm. And again, these are young women. They're in their 30s or 40s, for them to become, asexual and not interested in sex anymore is tragic.
Yes.
It's ended a lot of relationships. There's a lot of bone loss after hysterectomy, urinary leaking. Like I tell patients, next time you go to the drugstore or the grocery store, go to where they sell adult diapers.
You do that too, huh?
If you don't believe the urinary leaking after hysterectomy, who should you see on the packaging? Because Depends, they're like smart marketers. They're like from Kimberly-Clark or one of the big, they're smart, Madison Avenue marketers. They know who their customer is. So who you should see on the package of Depends adult diapers should be a picture of my dad. He just last week turned 96. That's who you should see. You won't see him. You'll see a young attractive African-American woman. Why? Because the average age of hysterectomy is less than 40, as I mentioned, and those are the people that need the diapers. It's crazy. In fact, I have an article, like an advertisement in my office. It's from Depends, and it's this attractive, thin African-American woman who's wearing an adult diaper. You see her from behind, and she's scooching on her skinny jeans over her adult diaper, and they're saying something cute like, "They'll never know your secret." What? Why does this woman need a diaper? Please tell me that. They don't talk about that.
People don't understand the marketing. You know, you said it. It's one whole aisle in every supermarket across the country dedicated to incontinence. And people look at me like, "Really?" I said, "Just go any aisle. You know, you'll see it. A whole aisle of, you know, just for incontinence. It's unbelievable." And I sit there. I said, "You know, are there any issues with reimbursement or coverages?"
No, that every insurance company covers UFE. We'd say it's well proven, safe, effective. It even got endorsed by the American College of OBGYN. They had to address it at some point. I mean, it took them a long time. I mean, we were doing, you know, UFEs in the mid 90s. By 2008, they finally said that they gave it its blessing, the thumbs up. It's, you know, safe and effective. They gave it its blessing, August of 2008. So there's no issue with reimbursement. Every insurance company covers it. Medicare, Medicaid, all of them.
It makes absolutely no sense. I mean, you know,
you got to know about it. That's the thing, and that's unfortunate. You got to know.
Wow. You know, I mean, you know, I hope that after this, I mean, that you can somehow create a commercial for us so that we can constantly run your commercial over the network about this procedure. We just want to just constantly keep letting people know that this is available to them, not only in your area, but across the world. You know,
absolutely.
I mean, you know,
there's a huge need for this globally, but you know, as I say, it's really unfortunate that you have to know about these things. I mean, you can say women are entitled to know their options from their doctor, but they're not getting that. And you know, I appreciate, you know, having me on and talking about this, because this could be something that could really help a lot more women. We're just barely scratching the surface. I mean, there's probably 20,000 UFEs done a year, 25,000 UFEs a year, and there's hundreds of thousands of hysterectomies that could be, you know, converted to UFEs if people knew about it. And, you know, you don't even have to get that far. You know, you got hundreds of thousands of people getting hysterectomies, but how many people would benefit prior to even being sent for hysterectomy? As I say, there's lots. I mean, there's so many women to say it's an estimate of at least 1 million women that are on the sidelines just suffering. They don't want surgery. And so they just suffer with it. And I'm sure that's a low estimate.
I don't think there's enough interventional radiologists.
Wow. I mean, you know, for instance, I'll tell you a story. There's a story that we have on our website. I was asked by this company, we were shooting videos, and they were asking questions about UFE and fibroids. And then they kind of threw this kind of thing from left field. And they said, can you tell us about a patient that you'll never forget about? And I had to think about it for a moment. And I thought about this woman that I had met. She was in her late 30s, like 38, 39, and single. She was suffering miserably from fibroids. She went to her gynecologist, and the gynecologist said, you know, you need hysterectomy. And she's like, what? Like, I thought we were following these fibroids. And you're like, well, we are, but now you're having more symptoms. They're growing. You need a hysterectomy. That's it. She's like, I don't get it. Like, that seems very extreme. Like, I don't want hysterectomy. Well, that's what you need. And she's like, and she was hesitating. And he's like, well, I don't understand. Why are you hesitant? That'll make your life better, and your fibroid saga will be over with. And she's like, well, you know, it seems very invasive, but also I think, you know, I might want to have a child someday. I've never had a child. And he's like, you're 39 and single. I think that ship has sailed. And she was crushed. I mean, totally devastated. She's telling me this in the office. And I'm like, I am so sorry. I mean, that is such a crass, uncaring thing to say.
That's
and
horrible.
I don't know if you're going to, you know, I don't know if you'll ever get pregnant. I mean, but what I can tell you is I can help you, and we can make your life better through this procedure, UFE. Let's start there and try to get you well. And then let's see what happens. And so we treated her. We did a UFE on her. All of her symptoms went away. She was really happy. And not long after, she met a man, and they started dating, and they ended up getting married. And so they were married, and lo and behold, they get pregnant, and they have a child. And she sends me this incredible letter, handwritten, like with a baby picture that I have in my office. Thank you. You know, this is my miracle baby. I was this close, you know, to getting a hysterectomy. I'm so glad that I didn't do this. And, you know, thank you, so forth and so on. And then fast forward to about a year or so, year and a half ago, there's a knock at, you know, at the door of my office, and this woman came in, and it was this woman, and it was, you know, one of my front office staff says, there's somebody here to see you. And I'm like, oh, we're done seeing patients. Who is it? And she's, I don't know. She said she had to see you. So I'm like, okay. I walk out, and it's this woman, and she goes, I don't know if you remember me, but you did this UFE procedure on me. It's been almost 20 years. And I did great and so forth, but I wanted to show you something. So we walk outside, and out of the driver's seat of the car is the miracle baby, Jalen. He had just graduated from high school, and he came and gave me his high school graduation picture. So I said, okay, Jalen, come on into my office. I want to show you somebody. And I went to the bulletin board where all these baby pictures are, including his. And I said, do you know who this handsome man is? And so we now in my office, I've got baby Jalen and I've got high school Jalen next to each other. And I mean, you know,
That's
she
incredible.
was this close to getting hysterectomy.
You know, it's, you know, what I want to say, you know, that's an awesome story. I love stories. What I want to say in general is that is not only awesome, that's typical. A 39-year-old female that has difficulties with maintaining and having relationships because of a medical issue that can be treated. You know, that's, you know, how many women are suffering just like that socially, forget about medically, but just socially, because they can't have a relationship or they're uncomfortable with relationships because of everything that you've described.
Oh, yeah. And I mean, we treated Cynthia Bailey from Real Housewives of Atlanta. So I can mention that because she went public with her story. At the time she was married, and it almost, the fibroids almost destroyed their marriage because, you know, she was bleeding so heavily. Her husband, Peter, like from his aspect, all he could recognize was he wasn't getting his because she was bleeding so horribly. She was tired and weak and anemic and wearing adult diapers. She didn't feel sexual and was all this bleeding all the time. So the relations, you know, kind of slowed up. And so he thinks from his aspect, well, you know, relations are stopping. She must not love me. And so their marriage almost disintegrated until he realized she does love him, absolutely does. She was having this medical issue, and then, you know, they showed them that her getting treated with the UFE, and they filmed all this stuff. And then after the UFE, her symptoms went away, all her relations resumed, and everyone was happy. And, you know, she said, I gave her sexy back. And so I got that going for me.
Very good. You know, we're going to wrap it up with that. Gave her sexy back. I love that. You know what? Once again, guys, you know, I have Dr. Lipman here. You know, I'm hoping that people that you know, share this information with others, share this information with people you know that may be suffering from this problem. Reach out to us. You know, his information will be on our site. you know what, we're going to see if we can get a commercial with him going so that you could just call him directly. I don't care where you are. You know, give this man a call and say, hey, you know what, I need you. All right, you can get your sexy back, so to speak. All right, so